Introduction. This chapter is devoted to a discussion of the three most common skin cancers, which together form 95% of all skin cancer. These include the very common basal cell carcinoma and squamous cell carcinoma, both of which have their origin in UV light exposure, as the vast majority of cases can occur in sun-exposed areas. The other common skin cancer is malignant melanoma, which also tends to occur in sun-exposed areas, but usually arises out of a mole. The manifestations of these skin cancers, their treatment, and the complications of these types of cancer are discussed in this chapter. Skin cancers. There are several types of skin cancer, but more than 95% of cases of skin cancer are one of three types, including basal cell cancer of the skin, BCC, squamous cell cancer of the skin, CSCC, or cutaneous squamous cell carcinoma, or melanoma, also called malignant melanoma. Basal cell cancer is the most common type of skin cancer, often occurring on sun-exposed areas, such as the face. It presents as a raised, colorless lesion that spreads and ulcerates as it grows. The second most common type of skin cancer is squamous cell carcinoma, which also tends to occur on sun-exposed skin. Unlike BCC, patients with CSCC will have a scaly, flat plaque or a firm papule that enlarges and occasionally bleeds. The third most common type of skin cancer is melanoma, which is the most serious cancer of the three. This usually arises within moles because it is a cancer of the melanocytes, which concentrate in moles. It is often seen on sun-exposed areas, particularly the back and legs. It can spread to other body areas and can cause death at a much higher rate than BCC or CSCC. It can rarely be seen in hidden areas, such as the eyes, intestinal tract, and oral cavity. There are two types of melanoma, the superficial spreading melanoma and the nodular melanoma. Incidence and prevalence of skin cancer. Basal cell carcinoma of the skin is extremely common, accounting for up to a third of cancers seen and about 80% of all non-melanoma skin cancers. Squamous cell cancer is also prevalent, accounting for 20% of non-melanoma skin cancers. They represent about 90% of the cancers of the head and neck region. Melanoma is the third most common skin cancer, but is fortunately much rarer than either of the other two skin cancers. The incidence of malignant melanoma is about 20 out of 100,000 in the population, accounting for about 3 deaths out of 100,000 people. In the U.S., about 70,000 people are diagnosed with this type of cancer per year, with about 10,000 deaths in the U.S. occurring annually from the disorder. Predisposing factors for skin cancer. The risk factors for all skin cancers include being exposed to ultraviolet radiation, from sunlight exposure or tanning bed exposure to UV light, getting sunburnt easily, having pale skin, being exposed to arsenic over an extended period, or having many moles. People with skin scars will have a high risk of getting skin cancer within the scar itself. Having radiation treatments for another cancer will increase the possibility of skin cancer over the exposed area. There are genetic reasons for getting skin cancer, including malignant melanoma. Patients can rarely have an underlying genetic condition called xeroderma pigmentosum, which carries an increased risk of skin cancer, as can other underlying genetic diseases. Immunosuppression for any reason will predispose a person to develop skin cancer of any type. Signs and symptoms of skin cancer. Most patients with skin cancer will have no symptoms other than the findings of a skin lesion, which will fortunately be easily visible because they occur on exposed skin areas, such as the head and neck area or the forearms. Basal cell cancer will be a pearly, shiny, raised nodule, in most cases, that has no other symptoms. The larger and more advanced the lesion, the more likely it is that the lesion will ulcerate and bleed. Squamous cell carcinoma will present as a flat or slightly raised plaque. It can also be a hard nodule or an area of scaly skin. Usually, skin that can be easily seen, as the lesion will be in a sun-exposed area. Squamous cell cancer can come out of first having actinic keratosis of the skin, which are precancerous lesions on the forearms, face, or other sun-exposed areas. There are usually no symptoms of early malignant melanoma without evidence of metastases. There will only be an asymptomatic change in a mole or the start of a discolored papule with irregular borders on the skin. Metastatic disease will have symptoms, including pain in the metastatic areas. Clinical presentation of skin cancer. These cancers present themselves as an observable change in the skin that looks like any of the lesions described above. BCC will be seen as a shiny, pearly nodule that is sharply demarcated and occasionally ulcerated, while CSCC will be seen as a flat, scaly papule or plaque. Both will be seen on sun-exposed areas, such as the face and forearms. Melanoma will usually present in a change in a mole, particularly on the back or the legs, but can be in any sun-exposed area or even areas not exposed to the sun. There will be ulceration and bleeding in severe cases, but there are rarely any other symptoms to suggest cancer. Etiology of skin cancer. The primary cause of these skin cancers is the damage that occurs to the skin from exposure to UV radiation, ionizing radiation, or certain chemicals. There appears to be a genetic predisposition to getting any type of skin cancer, but particularly to melanoma. Patients who get these types of cancers not only have a history of pale skin, but will have a history of frequent sunburn or a medical problem with immunosuppression. Patients on immunosuppressive therapy for any reason will have an increased risk of skin cancer because they don't adequately get rid of the cancerous changes in the cells occurring because of UV radiation exposure. Pathology in skin cancer. Skin cancer can be a clinical diagnosis, but many patients will have the type of their skin cancer determined by a skin biopsy. Basal cell cancer tends to occur out of a cancerous change in the trichoblast cell in the skin, which is a folliculosebaceous apocrine germ cell. There is DNA damage from UV radiation exposure in the cancerous cells. Histopathologic evaluation of BCC will show multiple types, the most common being nodular basal cell cancer, which will have the pathology of BCC within a thick, pearly nodule on skin biopsy. The histopathologic evaluation of CSCC will show cancerous changes in skin cells, but will show less ulceration and more keratinization of the malignant lesion. The lesion is usually in the dermis of the skin, so the biopsy needs to include this area to find cancerous cells. Melanoma skin biopsies will show up as a change in a mole that can be seen visually and can also be seen under the microscope as a malignancy of the melanocytes. The gross pathology of malignant melanoma will often include asymmetry of a mole that can be colorless to black and usually variegated in color. The mole will have an irregular border with cancerous changes seen on the part of the skin, not necessarily an aspect of the original mole. Treatment and management of skin cancer. The mainstay of all skin cancer treatment is surgery to remove the cancerous skin cells. Sometimes an excisional biopsy will remove the entire cancer so that no further treatment is necessary. Punch biopsies of small lesions may remove the entire lesion. The lesion should be entirely excised to reduce the chances of a recurrence of cancer. Besides traditional surgical excision of the lesion, there is the Mohs surgical technique, in which shavings are repetitively taken from the skin and evaluated under the microscope. When a shaving is free of all cancer, the surgery is stopped, and it is determined that the skin cancer has been completely removed, with a limitation on the amount of healthy tissue removed. Both BCC and CSCC can be treated with cryosurgery, in which liquid nitrogen is used to destroy cancer through topical application directly on cancer itself. This tends to be a safe option because it does not involve surgery, removes very little healthy skin, and can be retreated if a recurrence occurs. Electrodesiccation and cutterage can be used for BCC or CSCC. In such cases, electrocautery is used to destroy the cancer, and cutterage are used to scrape off the dead cancer cells. The recurrence rate is like cryosurgery, which doesn't either depend on having a clear margin that is identified pathologically. BCC and CSCC can be treated with chemotherapy alone, particularly with the topical application of 5-fluorouracil or 5% imiquimod cream. Chemotherapy can follow Mohs surgery to get rid of any residual cancer cells not removed by direct surgery. Patients with malignant melanoma who have a metastatic lesion or several metastases can be treated with chemotherapy to reduce the tumor size and to possibly destroy all the cancer cells that cannot be removed surgically. The main complication of skin cancer is disfiguration, which can occur if the tumor isn't removed when it is small, or when the cancer is deep, so that a lot of tissue needs to be removed, causing disfiguration after surgery. The overall prognosis of BCC and CSCC is excellent because these cancers rarely metastasize. They tend to destroy local tissue first, with CSCC having a slightly greater potential to metastasize than BCC. Even so, less than 4% of patients with CSCC will have metastatic disease. The risk for metastases is extremely high with malignant melanoma, especially if it is deep and nodular or has spread over a wide area. With distant metastases of the disease, the average survival rate is about 6 to 12 months, with a less than 10% 5-year survival rate. The presence of metastatic disease in malignant melanoma portends a much higher risk for death than is seen in the non-metastatic disease.